Yeah, it's time to start. We have
Yes.
our speakers are online. Professor Ishu Bishnoi, who is my co-moderator, will join in a few minutes as he has some emergent cases to deal with. So welcome to all of you to this event today organized by the Alumni Association, Fujita Bantane Hospital. We have, of course, our mentor and sponsor, Professor Yoko Kato. Thank you, Professor, to be here. And a special welcome to not only my co-moderator, who will join soon, but also to our commentator today, my dear friend, Professor Raja Krishnankuti, and our discussants, Dr. Sukirti Chawan and Dr. Shanawaz Biswas. Today, we have the pleasure to have two eminent speakers, Professor Hirotaka Hasegawa from Japan and Dr. Kumar Abhishek from India. Before introducing the speakers, I would like to ask Professor Yoko Kato to give a short introduction to this webinar. Thank you, Professor.
Thank you. So hello everyone. So through my laptop, so everybody it looks very nice. So thank you very much, Hirotaka Sensei. So many times your support the SNS education activity, and your topic is really nice. And I think maybe this week that we will have some skull-based teamwork conference in Tokyo. So maybe that is your the main conference, I think. And Abhishek, thank you very much for your dedicating to the department. So that he works and his research, he studied a lot during the last 2 months. So that his topic is really, really, really
Thank you so much,
interesting.
Professor.
Thanks so much. Okay, so let's start.
Thank you, Professor Kato. So I want to introduce our first speaker, Professor Hirotaka Hasegawa. Professor Hirotaka Hasegawa is, first of all, a dear friend of mine and in general of ACNS. So I'm very happy, Hirotaka, you accepted our invitation. Thank you so much. Professor Hasegawa is Associate Professor at the Department of Neurosurgery at Saitama Medical University in Japan. He has an extensive clinical and research experience in skull-based surgery and cerebrovascular surgery, with a particular interest in endoscopic surgery for pituitary neuroendocrine tumors, meningiomas, craniopharyngiomas, chordomas, and chondrosarcomas, and also on stereotactic radiosurgery. He had a training in Tokyo, but he also had a fellowship for 2 years in the United States at the Mayo Clinic. And he is board certificated in Japan, and he is member of several scientific societies. He published about 125 scientific papers in national and international journals, and he is serving as a reviewer for several scientific publications. He has been also the recipient of several grants and prizes. And today he is going to talk about creating strategies with 3 blades, a neurosurgeon's journey to save lives, not just to remove disease. It's a very intriguing topic, and I'm sure it will be very beneficial, especially for young neurosurgeons who are the target of our webinars. So thank you very much, Hirotaka, for accepting our invitation, and you can start your talk. Thank you.
Thank you very much, Alberto, for a great introduction. I, I feel very embarrassed because you you say too much. And also, it's very honored to be here, and I really appreciate it to Professor Yoko Kato and every members of this great society. So today I'm going to talk about creating a strategy with 3 blades and neurosurgeon's journey to save lives, not just remove disease. I believe this concept is very, very important. So let me get into my talk. But before starting my talk, do you know this character here? This is the name is Ronono Zoro. He's one of the main characters and the swordman of the pirates. They're called One Piece, which is a world famous Japanese manga series. And he is very famous for his 3-sword style, where he wields a sword in each hand and one in his mouth. It's an unbelievable strong man. Actually, I don't have any blades at all because of the act for controlling the possession of firearms or swords and other such weapons in Japan. However, I have these 3 blades: microscopic transcatheter surgery, endoscopic transcatheter surgery, and stereotactic radiosurgery to tackle skull-base tumors. And today I'm going to talk about these 3 modalities and how to combine these modalities. So before jumping into the talk, let me introduce a little bit about my center. I'm from Saitama Medical Center, Saitama Medical University, which is here in Kawagoe City, just north of Tokyo here. And Kawagoe is very famous for its, the classic Edo period street and buildings and that kind of things. And we call Kawagoe as Little Edo, so called Edo. And this is my center. It's like Mont Saint Michel, but it's SMC, Saitama Medical Center. The hospital capacity is 1,053 beds. So it's kind of a little smaller than Fujita University, but it's still big university. This is my department. The total member is 20, 15 in-house and 5 at affiliated facilities. I'm one of the staff surgeons, and we also have trained surgeons and some other subspecialty fellows. The annual surgical volume is 700, from 700 to 800 cases, with a wide range of cases, including stroke, tumors, skull base, pediatric, trauma, spinal, that kind of things. So the case, my personal case volume is about 80% of the skull-base surgeries, and including 50 endoscopic endonasal surgeries here in Kawagoe City. And we are open to surgical observerships and enthusiastic fellows eager to participate in skull-base surgery. So please contact me if you are interested. So I like this phrase: tactics win battles, that strategy wins war. What this mean? This means you can win the battle with technical skill, but that alone does not win the war, which also means you can succeed in the surgery with technical skill, but that alone does not mean to save the patient. Here, tactics means mastery of technical approaches like dissection techniques under the microscope, instrument handling in endoscopic surgery, precise treatment planning. And the strategy means to judge what, how much, and in what sequence to perform to treat the lesion, like gross total resection, or we could do subtotal resection plus SRS, or endonasal surgery versus transcranial approach. So I believe it's very important to create a strategy to tackle skull-base tumor. Let's say, some say just go for gross total resection for, let's say, the vestibular schwannoma, but it may end up in facial palsy or post-operative complications leading to worse quality of life. Or let's say skull-base meningioma, we see that. Let's monitor with radiosurgery. In 2 years, tumor progresses and subsequent difficulty with reoperation. It happens. So the takeaway is we have to think beyond the surgical approach to include patient background, like age, comorbidities, or patient desire, quality of life, and planning for even recurrence. And also, we gotta distinguish tumors that can safely be left versus those that must be fully resected. And also, we have to decide what modality is the most effective and the least invasive. Invasiveness is also very important. So I think, like I said, these three approaches are very important, and we have to master as a skull-based surgeon these three modalities. At least we have to know the pros and cons of each modality. So let's dive into microscopic transcranial surgery first. As you know, microscopic transcranial surgery gives us wide operative field, direct visualization, very straightforward surgical area, and it's very versatile. It's virtually we can use microscopic transcranial surgery for I think any cases. So this is the example of leveraging the strengths of microscopic transcranial surgery. The patient has medial sphenoid ring meningioma. She presented with cognitive decline and multiple falls and some weakness and decreased vision because of the optical invasion. So because of the tumor is super large, and you see here, there is a carotid artery just inside the tumor, and also the M1 and A1, they are all trapped inside the tumor. And so we have to do meticulous dissection. And also the tumor is very big and laterally located. So we have to create a lateral trajectory. So definitely we should do microscopic transcranial surgery. This is the standard for temporal Alumni with clinical technique. I did that. This is the optical. And after that, I opened the dura. This is the tumor here. I dissect the cerulean fissure and that dissection of the brain tissue. The first we gotta do the walking and then the dissect. And then after certain debug, we have to follow the course of major arteries like NCA and ICA. And then we can divide the tumor into smaller pieces. And then we follow further smaller arteries. This time this is a P1 operator, PCOM, and anterior carotid arteries. We have to follow arteries in order not to injure these important arteries. And then coming to the medial side, this is the A1, always follow the course of the major arteries. Push the tumor to the medial side to completely dissect the tumor off of the anterocardial and posterior communicating arteries. And these are the perforating arteries from the top of the ICA and the A1. These arteries can even be dissected using the microscopic techniques. So this is the last view. The tumor is completely out, and the perforating arteries are actually, unfortunately, she got small infarction here, but after rehabilitation, she regained her neurological function and discharged home after rehabilitation. So the next one is endoscopic transcranial surgery. This is very famous for its minimally invasive access to midline/paramidline tumor. And then it can give us magnified and panoramic visualization. Definitely, I believe the visualization of the deeper field is better than microscopic transcranial surgery. So this is an example. So the patient has posterior clinoid meningioma, complexing the adjacent structures, including brainstem and optic nerve and chiasm, and it also traps some arteries like PCOM is here, the basilar artery touching it. So the point is we have to preserve the perforating arteries and all the cranial nerves complexing these that are complexed by this finesse tumor. And to do that, so let's think about if you do this with microscopic transcranial surgery. I believe I don't think you can see the entire tumor from any single approach, right? So you have to use at least combination of two transcranial approaches if we want to do from the lateral side. However, if you do pituitary transposition from the midline approach, you can see the entire tumor in the same trajectory. And I believe this is the very beautiful point of endoscopic transnasal surgery. So this is a very wide opening from granum all the way down to the foramen magnum. I took out the posterior cranial process and open the dura to start removing the tumor from the above. This is the superior hypophyseal artery. Definitely you have to preserve it. And you can see that PCOM here is completely embedded inside the tumor with its operating artery. So I first come to the midline side to open up the tumor, just following the course of the major artery, like I said, all the way follow the course of major arteries to divide the tumor to smaller pieces. And then coming back to the left side to dissect the tumor off of these PCOM and its operating arteries using some shots. First, I took out the tumor, the midline tumor, and then took out the right side, and then coming back to the left side, starting dissection from the dissection of the tumor off of the important artery. And this time that is a PCOM and the third nerve and the fourth nerve, fifth nerve, and sixth nerve, and everything. And then this is the final view. You see the third nerve and the fourth nerve and the anterior side of the brainstem. So it's very versatile approach if the tumor is sitting in the midline. So the surgical result is excellent. We did near total removal without causing any diffusion high spot at all. So the third modality is radiosurgery, gamma knife. As you know, this is not minimal invasive. This is non-invasive because it virtually causes no procedure-related complication at all. And it's a kind of long-range weapon that can bypass surrounding tissues, even if there are multiple, adhesion and scar tissues, no relation at all. And then the beauty of this radiosurgery is pinpoint targeting of the lesions. So this is the last case. We did near total removal, which means we left a small piece of the tumor just backside of the lateral clival area because I couldn't reach that area from the the medial endoscopic transnasal route. So we may say that there is no residual tumor, the MRI looks great, but I know as a surgeon there is a residual tumor. So I did gamma knife targeting the area that I believe I left a tumor, which is the left side posterior cabana sinus, and then the lateral clival area like this. Now she's at 2 years from surgery, no recurrence, no symptoms at all. That's the beauty of the combination of endoscopic nasal surgery and the stereotactic radiosurgery. So what about the combination treatment of microscopic transcranial surgery and the radiosurgery? So this is the, actually, this is a recurrent case. And after previous craniotomy, which ends up in, I think it's just a partial resection, so that the most of the tumors left intact. And then the tumor progresses and progresses, causing visual disturbance. So I believe there should be tough adhesion because of the previous procedure. So I don't think, and because the tumor is here, and there are multiple arteries like A1 and then the top of the ICA. These arteries are kind of trapped inside a tumor, and then I believe there are multiple adhesions that cannot be lysed easily. So I believe subtotal or near total resection plus radiosurgery would be the best idea. So I reopened the previous standard frame from the army, and I also add autonomy to widen the subtle field. This is the optic nerve. So this is a very famous part of this surgery. This is a humorous artery. But this tumor gets multiple tumor feeding from the artery. So I needed to take a long time to dissect the artery. So this is the final view. But because of the tough adhesion in this area, the base of the frontal lobe, I had to leave maybe 2 or 3 millimeters, very tiny sheet of the tumor. But I know as a surgeon, there is a tumor, there is a remnant tumor. So this is a remnant tumor, maybe including some scar tissues, but I know that there is a tumor, so I added radiosurgery, and now the patient is 2 years from the surgery. There is no recurrence. She doesn't have any symptoms, so the outcomes is very nice for now. What about the combining all those 3 modalities? So I think this is one of the most difficult tumors in the world. This is the cavernous meningioma, abutting to the multiple sides, like basal ganglia, the temporal lobe and brainstem, and the skull-base regions. So first, actually, this patient was referred to us before the first treatment, and then the patient was first one that underwent transcranial surgery at the previous hospital to take out the tumor that can be accessed from the lateral side, like the lateral to the lateral cavernous wall, and superior to the superior to the carotid artery and optic chiasm. But optic chiasm, carotid artery, lateral cavernous wall, from the lateral approach using microscopic transcranial trajectory, they cannot reach these regions because it's just too difficult. So, and then also, what's more, this patient has the carotid artery aneurysm on the same side. So I have to also take many care about this aneurysm. So this is a surgery. I did endoscopic transnasal approach, opening up the lateral side as well. So the first, this is the big treated gland, and this is the carotid artery. And then open up the lateral side. You see this is the carotid, and lateral to that, you can see the lateral trunk. This is a fourth nerve here. Keep a dissection of to injure these nerve fascicles, and then coming back to the central area to open up the tumor, removing the tumor attaching to the optic nerve just for the radiocell down the rod. So you see, by the way, you see the aneurysm here. So it's even very dangerous actually. So after that, I took I think 6 PDS to make a lot of suture. And with some nasal left, completely seal it, and that's it. So I did subtotal resection, but we know that there are residual tumors around the membranes and deep inside the cavernous sinus. So, but now, because we did a significant reduction of the tumor, now the chiasm is completely off from the tumor. So we added gamma knife, and now she doesn't have any recurrence and she doesn't have any neurological symptoms. It's really beautiful. Now she's 2 years out from the last surgery, but she's completely okay and she returned to her job. What's more, I have introduced 3 blades, and I think this can be the fourth one. Endoscopic minimally invasive transcranial surgery, the minimally invasive option. So this is the 60-year-old male recurrent petroclival meningioma after radiosurgery. So we must anticipate bad adhesion from the tumor and the surrounding tissues. We could do endoscopic transnasal surgery, but with that midline trajectory, I think we can only access to the medial half of the tumor, and then the vast majority of the tumor area cannot be reached. So this time, I believe the anterior transpecular approach is the best one. So sorry for that video. So in compared to the conventional anterior transpecular approach, with the endoscopic minimally invasive anterior transpecular approach, you don't have to make any big craniotomy. So I just cut 7 or 8 centimeter small skin incision here above the zygomatic arch, and then create 3.5 centimeter craniotomy, and then introduce exoscope first, and then taking endoscope to resect the carotid triangle, just like the microscopic anterior transpecular approach. And then attach the tumor. This is the tentorium. You see the tumor and fourth nerve here. You see how bad the tumor is attaching to the sphinx nerve and some other caves. Oh, sorry. The adhesion is really bad. However, with the panoramic view of the endoscope, sorry, I don't know what happened. With the panoramic view of the endoscope, oh, no. Oh, sorry, the video has stopped. Let me restart. Sorry, probably my surgery is too complicated for this computer. Sorry about that. We're gonna restart.
Can you reshare?
All right, I'm gonna share my slide again. Sorry for the delay. Oh, no, it's not the one. Sorry, this is not the one. This is my slide.
Yeah,
Yes,
we
we can see.
Okay, sorry for the confusion. So anyway, this is the endoscopic section of the colossal triangle. The resection of the colossal rhomboid. And then cut to chorion. You see the tumor. You see the fourth nerve here. Then there is a bad adhesion between the tumor and the sixth nerve. It's our component in the microscope. And now coming back to the back side, find the surface of the brain stem, so in dissection from the posterior side to find the fifth nerve and the sixth nerve here. You see the lateral artery by the way. Because of the adhesion is super tough, I believe I couldn't do the gross resection. So this is the top of the lateral artery. So I tried the near total resection with a small part of the tumor attaching to the cranial nerves and brainstem directly in place. This is the final here. Actually, I took almost the tumor, but you see the tumor in the Kipara sinus and then the attaching to the brainstem. But the beauty point of this surgery is that how small the craniotomy is. You see that? So the patient's recovery time is really fast. So the surgery looks good. You see that some remnant tumor here and there, which actually this time the patient has the tumor turned out to be atypical meningioma. So I sent him to the radiosurgery again. So there are three approaches, like I said, and then we have to understand the pros and cons of each modalities. So microscopic transcranial surgery is very nice for lateral skull base, but if you target midline or paramidline tumors using this approach, you have to cross cranial nerves, which means you may have the possibility to injure these nerves. The endoscopic transcranial surgery is the best for ventral midline to paramidline skull base tumors. However, we cannot reach the lateral regions with this approach. The radial surgery can treat anything. Like I said, it's a long-range weapon, so we can bypass post-operative adhesion and scar tissues. However, it also has the risk of adhesion formation, and it doesn't have any immediate effect. So these are the downside of the surgery. So we have to understand these points. So the other triple modality surgeon, I believe skull-base tumor is very, very complex. So when you wanted to do, if you wanted to do successful treatment, you have to keep in mind right tool in the right place mindset. So I would, this is my treatment philosophy. I would aim for gross order resection when safe and feasible. However, we may choose staged control with functional preservation when necessary. And staged means not just staged surgery. It means staged surgery and radiosurgery, staged surgery, endoscopic surgery, and radiosurgery. Anything will happen. And so, but I would say if the lesion is medial to the cranial nerves, I would say without hesitation, endoscopic transcranial surgery. And if it's lateral to the cranial nerve, I would say microscopic transcranial surgery, no hesitation. And if there is a critical adhesion, I would say lead it and target with SRS. And now we also have the fourth blade, which is the endoscopic minimally invasive transcranial surgery, unless giant tumors. But just so you know, upfront SRS may be considered, especially for the vestibular schwannoma and some small meningiomas, but I wouldn't do SRS in younger patients as it can limit future options, especially now that surgery is less invasive. So I would also reiterate the advantage of being proficient in all three modalities. The first one is unbiased modality flexibility. Because we know the pros and the cons of each modalities, we can choose the most suitable treatment modality with very flexible mind. And also strategic subtotal resection can be possible because we know that, hey, this is a schwannoma or meningioma. This volume of meningioma is fine. It can be treated with SLS. We know that. So we can leave it to the radio surgery. So we can stop there. And then also the integrated planning is very important. Residual tumor are well understood by the same surgeon, but the residual tumors are really difficult to understood by radiation oncologists. As an gamma knife surgeon, I always check the treatment planning for my patient, even after I send the patient to the University of Tokyo for a gamma knife. I check all the treatment planning to aiming for integrated planning. And also comprehensive ownership is very important. The translator surgery and the surgical surgery are not delegated. It's a comprehensive care is provided directly by the primary surgeon. And I believe this mindset will reassure the patient very much. So in conclusion, tactics, technical skill alone does not complete the treatment of skull-base tumor because it's very complex. What is truly required is strategic judgment to determine when, how far, and how to combine modalities and create individual strategies. Thank you for your attention.
Thank you very much, Professor Hirotaka Hasegawa, for the wonderful presentation. I think we can start the discussion, and I would like to kindly ask our commentator, Professor Raja Krishnankuti, to give his comments or questions. Thank you, Raja.
Well, yeah, thank you, Alberto. First of all, it's a pleasure to watch these wonderful surgical skills. Congratulations, Professor Hasegawa, for showing us how it is done. And it's like you said, it is always a great advantage for a surgeon who can handle both endoscopic, endonasal, minimally invasive, transcranial, and SRS. You have the patient with you all the time rather than sending the patient away. Well, the question I would like to ask you about is what are your options of reconstruction in such complex? I understand you have showed us earlier also, just for the sake of who they were not there, the reconstruction techniques following complex endonasal resections. Can you please share it with us?
Yeah, thank you very much for asking that. That's a very important and a crucial point for endoscopic surgery, because if you cannot do any reconstruction, you will fail the patient. You will probably kill the patient because of the CSF leakage can cause the meningitis, which can be fatal. So I think reconstruction is one of the most important part of endoscopic surgery. And then, in my practice, I think there are several points, but the first one is a multi-layered reconstruction. This is very important. You have to use not just one single layer, but you have to do 2, 3, 4, 5, many layers. To me, my first layer is duragen, which is a collagen sheet, and the second layer is fascia, and then the third layer is only fascia, just another layer of fascia, and then the some bone graft as a rigid plate, and then mucosa. I'm not I don't mean the I'm not saying the nasal flap, but I would use the sphenoid mucosal flap just for the sake of the nasal QOL, nasal quality of life, I mean the nasal function. So these multiple reconstructions are very important. And then the second part is suture, dual suture. I've already published the article regarding the watertight dual suturing in the endoscopic transcatheter field. And then if you do watertight suturing, which is a little bit challenging, I mean, for the beginner surgeons, but if you master it, you can be, very confident in endoscopic transcatheter surgery for any part of the skull base. It takes time, maybe 40 minutes to 1 hour. Like I throw probably 12 or even 14 or 15 knots. It's really it really takes time, but it contributes to the safety of the patient and the safety of your life also. We don't want to disturb our sleep during the night due to the call from the resident, hey, the patient has a CSF leakage, and that's it. So I don't like that. The last one is, I think, rigid buttless. The rigid buttless is very important because it can, counter the CSF pulsation, right? So any rigid reconstruction is fine, but for me, so first I used the sinonasal balloon, like I inflate using the 5 millimeter water, that kind of things. It's okay, but I encountered one patient who retract by himself because of some derailment or the kind of things. So after I met that patient, and I had to do skull-base reconstruction for that patient because the patient self-retracted the nasal balloon just after the operation. So after I experienced that, I changed my mind and then started using rigid reconstruction as a gasket seal to completely kill the CSF pressure. And then I think these three factors are very important for safety.
And do you use a lumbar drain in the preoperative setting in such patients?
No lumbar drains at all.
And in which layer do you augment it with fibrin glue?
Maybe the last layer. I mean, the last layer, I use the adherers. You know that the greenish, some weird sealant from Stryker. That's a very nice, very tough sealant. But in between, I mean, after I put the bone back as a rigid plate, I think I placed some fibrin glue, but that doesn't mean it's very strong. I'm not relying on fibrin glue at all.
Okay, the conventional technique, which is the fat fascia and fibrin glue, the 3F technique by the Italian group. I think Alberto, before doing that in his practice, what do you think, Alberto?
Actually, that was my question. Following your question, Raja, Hirotaka, you didn't mention fat, which we usually use in these cases. You don't use fat at all, or in selected cases? What's your opinion about that?
Thanks for the question. Actually, I use fat only for filling the dead space. Like transcriber approach, we have to do a lot of drilling to remove the big chunk of the bone. And then after that, I put some fat tissue to just fill up the dead space. I don't like the dead space, and that's it. I don't think we need fat tissues for the anterior skull base tumors and that kind of things. But how I say, this is kind of this is just my own technique. So everyone has their own technique, so which is just fine. So far is I think far is very convenient, and even though let's say Osaka team, Professor Goto, they love fat, right? And then their CSF leakage rate is excellent, right? It's almost zero. I think far is very, very nice also.
I agree.
I don't.
I agree with you that there is not the perfect technique, right? Every surgeon has to find his own best way to manage problems. And I think all these tricks and tools should be, in the armamentarium of neurosurgeons, and then you can select based on your own confidence, based on your experience, which ones to use. Personally, I do use FET if I have a CSF leakage. I not only to fill the empty spaces, which I agree with you, but also I use small pieces of fat to, I use them as some small tampons in the periphery of the
Yeah.
dural
Yeah.
of the dural defect before using fibrin glue or before covering that part with an esoseptal flap. So these are all very different techniques, but there is not the perfect one, but you have to know all of them and then choose the best for your own or for your specific patients.
Exactly, and I agree with you. And I also use the fat for that purpose to fill up the space, in the marginal area.
Right. Right.
Yeah. No, only my only I think the only downside of my technique is it's a little bit technically challenging and it takes time, right?
Yeah, yeah,
So
right.
that's also a problem, right? So
You are right.
the learning process is also very important. So
Yeah,
yeah.
yeah.
That's my the next problem to be solved.
Yeah. Thank you. Raja, do you have other comments?
No, we can go ahead.
Okay, thank you, Raja. I see two raised hands. The first one, Dr. Biswas, our discussant.
Thank you, Sensei. It was a really excellent presentation. I mean, New Horizon, sort of hybrid system, transcranial, endoscopic, and SRS by the same surgeon. Since I would like to ask a question as per the case shown here. In the medial sphenoid wing meningioma, there was a perforator-related infarction. I just wanted to know whether it was due to vessel or something like that. And if we use papaverine after handling the vessels or the perforator, will there be any benefit in this case?
Yeah, actually, I agree with you, and I believe that infarction was caused by some vascular spasm because I completely preserved every perforating arteries. So I believe I did electrophysiological monitoring for this patient and MEP, and then at that time I did some dissection around the PCOM. The MEP got down a little bit, but at that time, I stopped it and then I did another thing, and then the MEP signals comes back, so I didn't take any special care about that part. But I believe that I believe in that moment, the vasospasm started happening, and then so yeah, I think papaverine would be the best choice for now. I don't know. I can't come up with any other solution for this type of vasospasm, and I believe that we have to stop each time when we notice some weird thing is happening, and we have to take meticulous care in the surgical field, maybe fill up the normal saline using some papaverine, that kind of thing. So yeah.
Okay. Thank you. Sensei, and regarding the intranasal endoscopic, you do the pituitary transposition. So you do the total transposition in one side. So is there any event where you have pituitary hyperfunction due to laceration of the pituitary gland? Or you would like to share any tips to safely transpose the pituitary gland? Because yeah, we
Okay.
have to go through the paracellular ligaments and the caroticoclinoidal ligament. So quite technically challenging for young like us.
So first, what's your target? Because if it's a craniopharyngioma, I don't think you have a good chance to preserve pituitary function. So
For
you
the
just take
cavernous
out the
sinus
pituitary.
meningioma, cavernous sinus
Okay.
lesion.
So
I mean,
with
in
cavernous
general,
sinus,
when you want to go for the pituitary transposition, I would like to share a few tips in this regard, just to avoid postoperative pituitary hyperfunction.
okay, good. So I don't think I have any special tips, but first I find the pituitary gland at the midline, and then go lateral by dissecting the pituitary gland from the medial wall of the cavernous sinus and follow that course. Okay, and then I can reach the the back end of the pituitary gland, find the dura of the dorsum, and then I start cutting the floor, the floor, the dura of the cella floor, and then find the cavernous sinus there, put some floor seal to completely make an hemostasis, and then I will probably be able to find the posterior rest of the posterior cranial process and take that out, and then I finally cut out the dura of the dorsum cella, and then subsequently cut down to the clivus. That's my strategy.
I mean, did you ever face any postoperative complications due to pituitary hyperfunction?
I don't think so.
Any,
It's very rare. No. I mean, if it's craniopharyngioma, anyway, the pituitary function will go away. But if it's meningioma, just transposition, no hypopituitarism will occur.
Biswas,
Thank you.
unmute. Okay, thank you very much, Biswas. And I see Ben. Hello, Ben. You have a question?
Thank you, sir.
Yes. Hello, Hirotaka Sensei. Nice to meet you
Hey.
again. And thank you so much for your quick lecture. I would like to ask about the use of the exoscope. So in your experience, so how can the exoscope to what extent can exoscope supplement the microscope or the endoscope so that you have that you would choose exoscope instead of microscopic or instead of endoscopic. So what's the role of the exoscope in your free blade philosophy? Thank you so much.
Yeah, that's a very difficult question to be answered because I believe that's a never-ending discussion, right? So other than, I started my practice as a microscopic surgeon, so I'm very much confident in using microscope, and that's, I think, the only reason why I'm using the microscope over the exoscope. I don't think exoscope is a bad thing. It's a very nice, but just a little bit of preference. And then I think like in the current system, I think microscope would be, to me, more straightforward. Just like, I'm moving with the microscope and then seeing this angle like that. But if you use the the exoscope, if angle the endoscope, we don't have to angle it. But I sometimes do like this just to, yeah, make me feel this is a straightforward surgical field. So it will give me some weird sensation during surgery. So it's just my preference to prefer microscope to exoscope. Sorry, it's not a good answer.
No, it's not at all. Thank you for your experience because some surgeons are picking up on the exoscope, so and expanding it roles, and they may even use it to replace the microscope. So I would like to just see your view on this. Thank you so much.
Yeah, I mean, you could replace microscope using exoscope. That would be fine if you are very confident in using that. It's also I think they are very similar, but the advantage of the exoscope is it's low price, right? It's very I mean,
Yeah.
cheaper. It's much cheaper than the microscope, so it's very versatile. And then maybe I think you can use some, I think they will add some, applications onto the exoscope down the road. So once you get accustomed to using it, I think in the near future, that selection will provide a lot more benefit than we currently imagine. So yeah.
Thank
Thank
you.
you so much.
Thank you, Ben, and thank you, Professor Hasegawa, for the answer. Is there any other question from the floor? If not, we can close this discussion, and I want to thank again Hirotaka Hasegawa for the wonderful talk and active discussion. Probably you will not be able to stay connected, right? As you told me, you have another commitment very soon.
Sorry.
So we want to thank again, and personally, I hope to see you in person very soon. Hirotaka, thank you.
Yeah. See ya. Thank you very much
Thank you.
very much, Professor Kato and everyone. Thank you very much.
Thank you. And we can go ahead with the second speaker. I ask my co-moderator and friend, Professor Ishu Bishnoi, who is now connected, to take over and introduce our next speaker. Thank you, Ishu.
Thank you, Alberto. And good evening, good morning, and good afternoon, everyone. And I will be asking Dr. Abhishek Kumar to present his presentation. He is currently working as Assistant Professor Neurosurgery at RML Hospital in Lucknow. He did his MCH from Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. And he has published various papers. And currently he has done his cerebrovascular fellowship from Fujita Health University and skull-based clinical fellowship from Osaka Metropolitan University. And today he will be talking on contrast-induced encephalopathy in endovascular area. So I would like to ask Dr. Abhishek Kumar to present.
Thank you so much for the introduction, Sensei. Now I would like to share my screen. Is my screen visible?
Yeah.
It is.
So thank you, Professor Kato, seniors, my colleagues, and my dear friends. I had the privilege of doing the cerebrovascular fellowship from Bantane Hospital. I just finished last month end. And while observing my interventional neurosurgery procedures, we worked upon a case of contrast-induced encephalopathy, which is a rare but adverse outcome. And if we diagnose this early, the course of treatment can be changed. So it is very important. Otherwise, the treatment goes in the wrong direction. So through a series of 3 cases, I would like to share my the insights of the imaging strategy, management strategy, and all other things. Thank you for the opportunity. So this was the first case of a 63-year-old female with uncontrolled hypertension, and she had presented with a left-sided ICA ophthalmic segment aneurysm. So this is the baseline DSA. You can see the 2D projection, and this is the 3D reconstructional image showing orange is the aneurysm, and this is the parent vessel. So after doing the morphometric analysis and calculating the aspect ratio and the dome to neck ratio, it helped us to plan for a flow diverter with adjunctive coils for complete and durable occlusion. So this is the brief video of the patient, which shows with using the Vecta 71 distal access catheter, and we placed it in the ICA, ophthalmic area. You can see we successfully put the coils and also placed the flow diverter. and got a very successful occlusion of the aneurysm. So the procedure went very fine. But so to summarize the procedure, so we put a flow diverter using the Vecta 71 distal access catheter, and it was placed in the ophthalmic part of ICA. The total contrast used was 147 milliliters of ipomidol, which is a non-ionic low osmolar contrast agent. And the total duration was 140 minutes. So everything went well, but post-surgery, immediately after extubation, we found that the patient is having some stroke-like symptoms. Patient was having decreased sensorium, GCS was 9, there was right-sided hemiparesis, and there was aphasia. So we thought that there is some event has happened, could be thromboembolism or some bleed. So we shifted this patient for urgent imaging, and we also started the conservative management. So this is the series which we did. We got a post-operative CT scan which showed that left-sided frontoparietal area there were sulcal and gyral hyperdensities were noted, but the MRI was clear, not suggestive of any ischemia or any edema or any infarct. In that, this dual energy CT scan with iodine mapping came very handy, and it cleans the diagnosis of contrast-induced encephalopathy. So early diagnosis led to early intervention, and we could start the institutional protocol, which includes the aggressive IV hydration, which dilutes and clears the contrast, prophylactic seizures. We use anti-epileptics. Methylprednisolone we use for blood-brain barrier stabilization. Mannitol case to case, depending on the ICP, we use. And for controlling the hypertension surges and hypertension in patients of CIE with a known history of hypertension, we use nicardipine as a very safe agent. So dual antiplatelet was continued as procedure, as per protocol. In all cases, we use it. So it was used. And for vasospasm, we were using nimodipine as a prophylactic measure. So we achieved a full recovery within 24 to 48 hours. So this was the second case of a 73-year-old female who presented to us with a left-sided A2 segment distal anterior cerebral artery stenosis. So the length of the stenotic segment was around 5 to 6 millimeter, and the residual lumen was 2.2 millimeter radiologically. So we did a percutaneous transluminal angioplasty using Unriu 1.5 into 10 millimeter balloon, and you can see here this is the pre-procedural and this is the post-procedural. We attained a good satisfactory dilatation of the lumen. To summarize the procedure, we used a distal access catheter Sophia 5 French, and we placed it at ICA bifurcation. So I have highlighted the location where we have docked the distal access catheter, and the relevance I will explain in the future and further slides. Total contrast use was 162 milliliters. This is also highlighted for further explanation. Duration was 68 minutes. But to our surprise, again, this patient post-operative, we find a stroke-like picture. So standard in protocols were done. And again, in this case, DCT came as very handy. So I would like to emphasize, the sooner we know, the sooner we can turn the tide. So it is paramount to diagnose this condition. So new neurological deficits occurring post-procedure, and you have a very high suspicion of thromboembolism or any hemorrhage. So this DCT comes very handy in those cases. So patient improved within 24 hours and full recovered and discharged on post-op day 7. This is the third case of distal ACA aneurysm, which we can show in the CT angio and the DSA image at the bifurcation of the distal anterior cerebral. And for this, we planned and put the woven endobridge web device 5 into 3 millimeters. So we can see here there is a very successful and durable occlusion of the aneurysm. Summarizing the procedure, we used Vecta 71 distal access catheter, and it was placed in the IC siphon. Total 152 ml of contrast was used, ipomidol, same, and duration was 102 minutes. This patient also had stroke-like pictures. Also, this patient on the next day had 3 episodes of seizures. So showing that this patient had some kind of severe symptoms. Radiology, you can see that the contrast extravasation is more than the previous 2 cases which I have showed. MRI is clear. So DCT, it is mentioned in the literature also that DCT can provide a semi-quantitative estimate of contrast load within the brain parenchyma, which is a potential marker of contrast-induced encephalopathy severity also. So not only differentiates blood from iodine, it also is providing a semi-quantitative estimate. So in this case, you can see there is this more extravasation of contrast. The patient had severe symptoms. Also, this patient requires sedation and intubation. So he was sedated and intubated and kept for 4 days under sedation using benzodiazepine, propofol. So, but early intervention led to improvement. Patient on post-op day 4 was extubated following improvement of symptom. And on post-op day 12, patient had full functional recovery and patient was discharged. What is CIE? What exactly is CIE? It is a rare, reversible neurological complication which is seen after intra-arterial or intravenous administration of iodinated contrast media. So it could be coronary angiography, it could be cerebral angiography, or it could be any angiography. It is an adverse reaction due to iodinated contrast media. The reported incidence in cerebral angiography is 0.3 to 4%, and it is characterized by spectrum of symptoms. It could present with mild headache to severe symptoms like as coma, or even fatal outcomes have been reported. The center point revolves around the blood-brain barrier disruption and contrast neurotoxicity. So as I mentioned, there have been in literature devastating complications reported in which the diagnosis was delayed and the initiation of treatment was delayed and patient had lost also his life, unfortunately. What we know about pathophysiology of this disease? So as I mentioned, it is acute blood-brain barrier disruption in which the contrast media extravasates into the cortex and subarachnoid spaces, which results in the vasogenic edema locally and the direct neurotoxic effects of the contrast media. One important thing is that previously severity of blood-brain barrier disruption depended on the concentration of contrast and total contrast media. This thought previously in literature. Endothelial cells resulting in separation of the tight junction. But it is also observed in isoosmolar agents. Like in our 3 cases, we use ipamidol, which is 300 milliosmolar, which is low osmolar. But still we saw that this patient had CIE, thus opening a speculation that this pathology is multifactorial. What are the risk factors? So risk factor can be classified into patient related and also procedural related. So which patients are more predisposed for this condition? In which patient we have to be more careful? So hypertension is the most important risk factor and it is noted clearly in all the case reports and previous literature, because hypertension leads to chronic blood-brain barrier vulnerability. Diabetes mellitus, which is a very high risk factor for microangiopathy and endothelial dysfunction. Chronic kidney disease, in which the patient, the contrast excretion is very slow. Advanced age, where the autoregulation of BBB, blood-brain barrier is impaired, and also in patients with known case of stroke or microvascular disease. In this series, all 3 patients had unregulated hypertension before surgery. What are the procedure-related risk factors? So if you are using a high dose of contrast, more than 150 ml as quoted in literature, there is a risk. There is a prolonged procedural time. If there is a prolonged endothelial stress or repeated contrast exposure. If there is variability and surges of blood pressure in the surgery, which exacerbates the blood-brain barrier disruption, and if the distal access catheter is placed intradurally. It's a very significant and very important factor. So it has a jet effect and high local concentration of contrast delivery, which leads to repeated high pressure injections in same vascular territory. Hence, it is predisposing for blood-brain barrier fatigue and disruption. And very important, if there is a retreatment of recurrent aneurysm, so there is a very high risk of this encephalopathy. Now, I would just like to mention that distal access catheter becomes intradural once its tip crosses the dural ring. It's very simple, but just to mention it for the clarity. So distal access catheter, once it enters the dural ring into the intracranial circulation, it becomes intradural. So contrast injection from this position hit the brain circulation directly, raising the risk of contrast-induced encephalopathy. Now, it is very important to talk about distal access catheter. According to me and literature, what I have seen, hypertension as a patient factor and DAC, the distal access catheter position, is a very important factor. So, what happens is the contrast jet effect, hydrostatic stress. So, if the DAC tip is intradural or very distally placed, so there is a jet of undiluted contrast into small caliber arteries, which leads to increased the shear stress and mechanically disrupting the blood-brain barrier. Also, there is delivery of high local concentration. So, unlike proximal guide injections where the contrast disperses in large arteries, as when we inject through the proximal catheters, distal DAC catheters inject delivery of high concentration contrast into a very limited vascular territory. This localized contrast bath accelerates the disruption of blood-brain barrier. Also, there is a reduced washout. So, as we know that in smaller vascular beds, venous clearance is slower. So, contrast keeps on lingering longer, amplifying endothelial injury and parenchymal staining. Also, recent studies, especially to mention Otsuka et al., suggested that distal DAC placement is an independent risk predictor for this rare adverse outcome. So what are the practical implications? So you have to limit your distal access catheter runs to essential angiographic checks only. And you should prefer the proximal guide injections for routine angiography to reduce the risk of blood-brain barrier injury. One word I would like to mention, what is the difference what noted when we saw patients of contrast-induced encephalopathy when the patient went coronary angiography and what happened in cerebral angiography. So when a patient underwent coronary angiography, there was reflux of the contrast from the coronaries to the aorta. So there was a dilution of contrast in the systemic circulation before it reached the brain. So there was a diffuse exposure of the brain to the contrast. So the onset was delayed from hours to days, as published in literature. Also, there was generalized features of symptoms when it was seen after coronary angiography. Patient had symptoms of confusion, seizure, or cortical blindness. And in these cases, the dominant risk factor is the total contrast volume rather than the position of the catheter. Whereas in cerebral angiography, there is a direct intra-arterial injections which leads to focal high pressure boluses. And these onsets were seen very sooner, immediate post-operative. As in our study also we have emphasized. And there were focal deficits because of the local effect of the contrast. And the independent risk factors in the literature were intradural distal catheter placement and repeat high pressure runs. So for this condition, immediate CT scan should be done to rule out frank hemorrhage, followed by MRI, which helps in differentiating edema versus infarct, also helps in excluding ischemia. Dual energy CT scan is key to differentiate contrast staining versus true subretinal node hemorrhage. And you can do follow-up imaging to see the resolution of hyperdensity. So I also would like to mention that it's a game changer. It establishes the diagnosis of contrast-induced encephalopathy when CT scan mimics SAH. For an example, I would like to say that if a patient after surgery has developed stroke-like symptoms, now the surgeon is confused what to do, whether this patient has bleed, whether to stop the antiplatelet drugs, whether to reverse the coagulation profile, what to do, whether to so he's clueless basically. And if he stops antiplatelet or if he reverses the coagulation, So there is a risk that the flow diverter or any, there is a high risk of coagulation in the flow diverter, which is counterproductive. So in those cases, this DCT establishes a very early diagnosis and helps the surgeon to continue with the dual antiplatelet drugs. So it is paramount to diagnose and clinch this diagnosis very early. So in that, DCT comes as a very handy for the surgeon. Management strategies, you have to stop the further contrast exposure, aggressively hydrate the patient to clear out the contrast. Corticosteroids, which is helpful. There is no randomized controlled trial to prove that corticosteroids should be used, but it comes very handy in managing cases as blood-brain it seals and helps to regulate the blood-brain barrier disruption, reduces vasogenic edema and mass effect. Also treat and use the anti-epileptic measures promptly to prevent any further chances of seizure. You continue your dual antiplatelet, consider nimodipine for vasospasm, and case-to-case basis for increased ICP, use mannitol or hyposmolar therapy, and strictly blood pressure control should prevent any variation, any rise in the blood pressure in post-operative, because this can worsen the blood-brain barrier disruption and further worsen the symptom. So protocol of management is immediate imaging, aggressive supportive care, using hydration, steroids, seizure control, and raised ICP management yields recovery in most of the cases. However, still the management, the high quality randomized control trials are lacking. So what are the lessons from these three cases? I would like to share the insights which we learned from these three cases. So we see that distal access catheter in all these three cases was positioned intradurally. One was positioned at the ICA bifurcation, one was at ICA siphon and ophthalmic ICA. Despite the procedures being different, one case was percutaneous transluminal angioplasty, one was Webb, one was FD. So this repetition of intradural distal access catheter positioning as a shared feature strengthens the hypothesis that distal access catheter mediated focal delivery of concentrated contrast is an important procedural trigger for CIE. And every patient in this series had untreated and poorly controlled hypertension, making the link between the chronic hypertensive vasculopathy and blood-brain barrier vulnerability. So our papers or our research seconds what has already been in the literature, that blood pressure is a very important preoperative risk factor and it should be optimized before surgery properly and also intraoperatively. So it is the uniform presence of this key patient factor is consecutive set of CI cases says that this peri-procedural BP optimization is not optional, but it is central to prevention. And you can see that it occurred across the various device type, Webb device, flow diversion, angioplasty, coils. So CI is a physiology procedural problem, contrast kinetic, blood-brain barrier disruption, and not limited to a single device or technique. And all cases use the same low osmolar agent and moderate to high contrast volumes with variable procedure times. This highlights that contrast-induced encephalopathy can occur even in modern low osmolar agents or hypoosmolar agents when contrast is concentrated into a territory and the host blood-brain barrier risk factor exists. So low osmolar is not a guarantee of safety. So if you think that low osmolar agents we are using, we are safe, it is not like that. And in each case, DCT iodine mapping was used to early to distinguish contrast staining from true hemorrhage, allowing avoidance of unnecessary invasive or hemorrhage-directed therapies and enabling prompt conservative management. So DCT is not only nice to have modality, it is an essential triage tool in cases of such cases. And our standardized conservative protocol produced rapid and complete recovery in all three patients, including a case where severe deficits and seizures also required intubation. This provides real-world support that early recognition and standardized supportive care is frequently sufficient to reverse the clinical course. Also, you can see one interesting thing that all lesions were on the left side and all patients developed left-sided extravasation. What does it mean? So, and also this point is not previously mentioned in anywhere in literature. This is the first time we found this, and we are going to report this. That contrast extravasation to the side or territory of the treated lesion, left hemisphere in our series, reinforcing that the mechanistic idea that repeated high concentration injections into a target vascular territory rather than systemic contrast alone produce a focal brain barrier breakdown. So this territory linkage is important in interpreting and explaining post-operative deficits. So bridging the prior observations into practical recommendations. So limit your distal access catheter angiographic runs, favor proximal injections where feasible, and optimize the blood pressure pre-op. So the triad of intradural distal access catheter injections, untreated hypertension, and territory concentrated contrast exposure leads to this devastating disease. And early the dual energy CT scan guided recognition and standardized conservative protocol leads to rapid recovery, and it converts the we convert the prior scattered report on this topic into a implementable precautionary steps for everyday neurointervention. Thank you for your patient listening.
Thank you for the wonderful lecture, Dr. Abhishek Kumar.
Thank you.
Now I would like to ask Dr. Raja to give comments, please.
Well done, nicely demonstrated, Abhishek. Thank you very much. And you have come up with newer ideas. It's very nice. As you have rightly mentioned, the age, preoperative renal dysfunction, and distal access placement of the catheter are all important risk factors for contrast-induced encephalopathy, and also the importance of dual energy CT. I hope this will give further insights for early diagnosis in people who assume that there might have been some thromboembolism undetected, which is usually 0.1% in DSAs. We may be confusing it with CIE also. I think more insights for providing, and there is also some diagnostic criteria upon radiology and clinical described for this by Chu et al. I think. So I have not seen CIE in my clinical practice. Maybe Tushit would have seen. What about you, Tushit? Have you seen this?
Yes, it is there. And when I agree with Dr. Abhishek that when it is an intravascular injection or intracranial, that is intradural injections, there are some chances that patient develops. And even from our experience, even if you don't have dual energy CT, on plain NCCT, that is non-contrast CT, you can see a proper formed gyral pattern due to this contrast stagnation. And you can easily differentiate, okay, the patient is going for this kind of CIE. And by protocol, we load anti-epileptic and steroids beforehand of the procedure. When we are planning for purely therapeutic cases. In that cases, we load with 8 milligram of dexamethasone and 1 gram of levetiracetam for the patient in that cases. And I also want to emphasize that it is not only the brain. The eyeballs are also very sensitive in that part. We are forgetting that ophthalmic artery is very nearby. And when distal access catheter is, we have lodged into the internal carotid artery near the siphon or either in the cavernous segment. This high pressure injection for that local area may lead to the, this finding similar to the brain into the eye also. So we have also seen some cases with after after doing this procedure, patient may end up with some amount of chemosis into the eye and reduce in the vision. And the ophthalmological examination is almost normal. And usually patient recovers 5 to 6 days after this thing. All this usually responds to steroids.
That is very interesting to see the ophthalmological manifestations of contrast.
Since last around 7 years, I have seen 3 cases out of that.
Yeah, it is, I think, underreported. I think.
Actually. Yeah.
Right.
And again, you know,
what was the outcome, Tushit, of your 3 cases?
Only one patient had some amount of neurological deficit in form of visual fields.
Temporary.
Temporary. But for that one patient, it lasted for almost 2 months.
Okay.
Which was very annoying and nagging in that part, that you have to means, you know, convince that, okay, the procedure was for the brain and he or she is having this thing. But I can say thankfully it recovered. And also we are using a multiple drugs during for the general anesthesia purpose. For the pain killing reason, even if we have used diclofenac IV, it has also a almost similar kind of picture like contrast-induced encephalopathy. And sometimes it is very difficult to even you know, differentiate between that two. It is because of contrast or it is because of diclofenac.
Right, probably there is a misdiagnosis, right? Sometimes.
Yes. And second is one more thing I would like to say. For the endovascular treatment for the aneurysm, I understand it is there because we have some, in India, we are getting more cases of ruptured aneurysms. So vasospasm is always a killer. But during doing mechanical thrombectomy for acute ischemic strokes, this kind of encephalopathies are more frequent because the blood-brain barrier is already somewhat compromised due to the ischemic events. And when you use a large amount of contrast in these cases for the further checking and rechecking, there are more chances of developing this CI.
Do you use steroid during surgery? Always.
We always preload with it. It is our anesthesia protocol. They are very much highly trained for that part because we are going to use a lots and lots of contrast. And I do agree with Dr. Abhishek Kumar that diluted contrast is very important. You have to make some protocol in your cath lab that, okay, also according to the sensitivity of your machine. That what he showed is a Philips FD 20, I think so. So for that, you require a very little contrast concentrated in that part. For the Simons and some other, or mainly GE cath labs, you require more amount of contrast to make a good picture in that cath labs.
Do you keep a limit of contrast medium? Like I will not go beyond this ml of dye?
Yes. We do follow that 150 ml is more than enough. So always we start with 50 ml contrast and 40 ml saline. That is in total 90 ml. And after that, we usually use a roadmap on that or smart mask system. So that we don't have to use a repeated contrast injection for that part.
Right. Thank you. We can go ahead with the questions.
Like, this is terrifying. If there are small aneurysms ruptured, it's better do clipping because the incidence was going up to 3%. And if you're comfortable with clipping, just do it because in that case, there was small aneurysm, DACA aneurysm. I thought it should have been clipped.
Okay.
So no other questions from the floor?
I think most of the guys, they have first time heard about this contrast-induced encephalopathy. They're still digesting it.
Yeah. Well, actually, it's something I have also no experience about, I have to be honest.
Personally, I heard this for the first time. I started doing DSA for last 3-4 years. So thank you, Dr. Abhishek Kumar, for enlightening us with Because if you are going into this endovascular area, so
Yes,
should be
my
careful
honor,
with.
Sensei, my honor. Thank you.
Yes, congratulations, Dr. Kumar, because you pointed out a very uncommon event, or maybe not so much reported as we were saying. So thank you so much for your.
Welcome.
Is Professor Fawad online also? Maybe he wants to comment about this.
Thank you. Salam alaikum. Thank you. Greeting. Konnichiwa. Thank you very
Konnichiwa.
much. And,
Konnichiwa.
yes, as maybe you heard about earthquake in Afghanistan, we are busy in injured and martyred in this triple mass casualty cases in Afghanistan, and we are busy still. But this cases, unfortunately, and thank you for your presentation, Professor Abhishek Kumar, and it was
Welcome, sir. My honor.
yes, yeah, it was great. But in Afghanistan, unfortunately, we are still busy, but basic neurosurgery cases, unfortunately. Before was the war wounded cases, and now this the mass casualties and this earthquake, and still we use Hudson breast for doing craniotomy and fixation, but freehand spine fixation, and it is very terrifying for our poor people. And we are looking for you for international help, donating and helping Afghanistan and Afghan people as well. Thank you very much.
Thank you, Professor Pirzad. Issue, probably we can close the discussion if there are no other questions from the floor or comments. So I want to thank both speakers, Professor Hirotaka Hasegawa
Welcome.
and Dr. Abhishek Kumar, for really wonderful
Sir. Thank you.
and interesting talks and active discussion. I think we have at least one new fellow who can introduce herself. Dr. Evelyn Rojas, are you online?
Yes, I'm online. Hello, everyone. My name is Evelyn Judith Rojas. I am neurosurgeon from Peru. The last month, I complete one more month of training in Fujita Health University, when I learn a lot and refine my skills in minimal invasive surgery. And I'm so grateful with Professor Yoko Kato. In addition, Professor Yoko Kato connected with Professor Nakai for attending us the awake surgeries for gliomas, and I learned of Japanese technique. And the last week I attended the Congress Smith and the ANS vascular meeting in Marseille, and tomorrow I start my fellowship in Montpellier with Professor Dufault for learn more about awake surgery. My goal is to bring all this knowledge and this experience back to improve the neurosurgery care in my country. And it's probably in January of the next year to organize a course of awake surgery in glioma. Thank you very much. It's a great honor for me to be part of the Fujita Alumni Association. Thank you
very much. Thank you very much, Dr. Evelyn, for sharing your experience, and we wish you all the best, of course, and you are welcome to the Fujita Bantane Alumni Association family, of course. I want to ask Professor Kato if there are other fellows or maybe nurses who need to introduce themselves?
Today, I think maybe only they finished the introduction by themselves. I think Dr. Ozkan.
Dr.
So,
Otkan?
what did you learn the last 2 months? Maybe you can say one word.
Yeah, I'm Özcan Sönmez from Turkey. I'm neurosurgeon almost 2 years, and I complete my 1 month in the fellowship in the Bantan Hospital. First of all, I will thank to Kokoto Sensei for everything. It's very fruitful for me, and it's very busy, and it's very impressive experience for me. I have 1 month more, and I think it will be great. Thank you for everyone.
Okay, so Dr. Krishna.
Thank you, Dr. Otskan. And so, if there are no other fellows,
one more, Kusma.
One more.
Yes. Yeah.
Thank you, Professor Gato Sensei. So I'm Dr. Kusuma from Bali, Indonesia. This is also, I'm starting my 2nd month here in Fujita Health University Bantani Hospital. I've already spent 1 month. And for the last 1 month, I learned a lot of things. Mainly about minimal invasive surgery. I've seen the endoscopic endonasal approach for the cardiopharyngioma and many kind of pituitary adenoma with acromegaly, and also the mini pterional keyhole approach for aneurysm clipping in the MCA bifurcation mainly. Yeah, I learned a lot of things. And I hope for the next month I keep getting more experience here in Bantani Hospital. Thank you so much.
Thank you, Dr. Pratama. Thank you so much, and also to you, our best wishes for your fellowship experience in Japan. So I think now we can close this wonderful webinar. I want to thank again our speakers, and a special thank to our commentator today, Professor Raja, and also, of course, my co-moderator, Professor Ishu Bishnoi. Thank you also to Dr. Liu for his constant support. Thank you to our discussants, Sukirti and Biswas, and also to all the friends who joined, Tushit and Maruf and Ben and everyone else who helped in the discussion. Thank you so much to the new fellows and to Professor Yoko Kato, of course, and I kindly ask Professor Yoko Kato to give some final remarks before closing the session.
Thank you very much. Just I want to mention, because the 2 more, the fellow from Kazakhstan, those are the nurses, but they could not speak English, but we have a chance to learn the Russian. And sooner or later, or the one guy from Georgia, maybe that he can, that he can translate. Maybe he can bridge in between the nurses and ours. We miss them. I think we are so sorry about that. And I think that is the lecture, the Hasegawa Sensei is just, I wanted to ask what he left already, but maybe he has very strong I would say that it's kind of the radio surgery, because the Tokyo University is very famous to treat with the radio surgery. Maybe I think the recently many of the case we do not tackle the let's say. But I think radio surgery help a lot of the treatment. I think, except for the younger generation. Also, the Hasegawa Sensei will be still young, but he is going to the leader of the skull-based surgery in the future. So, and I'm sick that he is very hardworking fellow. That he, during his stay, that he wrote 3 papers. One of them is at least one our institute has quite a lot of case about such kind of the contrast-induced encephalopathy. I don't know why, but maybe we can treat the patient who has hypertension. Maybe we can treat at first the hypertension, then to treat the muscular lesion. I think that is a good way. And also finally, thank you very much, Forward. Every time you support us. We're so sorry about the earthquake in Afghanistan, but please do your best